My name's Nicola. I'm the Alumni Relations Officer for Kellogg, and I'm really pleased to welcome you here today. It's lovely to see people in these unusual times still showing up to support the college and hopefully learn something new. So today it is my very great pleasure to introduce our two speakers, Kamal Mahtani and Stephanie Tierney. Kamal is, as well as being Kellogg Fellow, he is an Associate Professor in the Nuffield Department of Primary Healthcare Sciences, where Stephanie is also a lecturer and senior researcher. And they are going to speak to us today about factors that can influence our health and well-being, which, under the circumstances, I think is a pretty pertinent topic of conversation. So, without further ado, I'm going to hand you over to Kamal and Stephanie.
Thanks very much, Nicola. Lovely to be here. Steph's just going to start sharing her screen. Hopefully everyone can see that now. I can see some nods, great. So thanks very much for, again, joining us today on this virtual meeting. It's a real nice pleasure, if we can't meet face to face, to be able to see each other or hear each other online. As Nicola said, Steph and I work together, Stephanie Tierney and I. I work also as a GP out in East Oxford. And then, as Nicola said, I work at the Nuffield Department within the Centre for Evidence-Based Medicine. And what we're going to talk to you this afternoon, this morning, both of us is going to talk a little bit about some of the research we've been doing, which is affiliated to Kellogg and our host departments, around social prescribing. So, shall we, Steph, do you want to just introduce yourself as well, just momentarily, and then we'll kick off with our slides?
Yeah, I'm going to do it without my face because I find it really distracting looking at myself and talking. But yeah, my name's Stephanie Tierney. I'm a health services researcher by trade. I have an ongoing interest in looking at experiences of living with long-term conditions particularly, but more recently thinking about how we can affect health and well-being by not just sort of medical practices, but also by drawing on things that already exist in the community. And we'll come on to talk a bit more about that later on.
Thanks, Steph. Steph, if you don't mind moving to the next slide.
Yeah. Sorry.
Thank you. So, as a GP, and I'm sure maybe others as well, as patients or clinicians or users of services, many of us will know that health services, whether in this country, and I've just put the sign up with the NHS, or in other countries, will know that health services and providers are under considerable stress. And if anything, the pandemic that we're currently under has shown that more and more. But this is not a new story. This is an ongoing story, the fact that demand is so high for health services. And I'm going to focus specifically in this first part of the talk about general practice, which is where I work. Next slide, please. Thanks, Steph. So increasingly over the last few years, and they haven't gone away, we're seeing headlines like this about reflecting some of the challenges that are facing general practice. So here's one in the BBC News: patients are at risk because the length of GP consultations are getting longer and longer. More patients are having to wait longer than a week for appointments, and now 1 million patients or more can't get an appointment within a week. And I'm sure if this was a live audience, as in we were together, I'd ask you if that's been some of your experiences, and I suspect the answer would be yeah, it's not easy to get hold of your GP when you need to. Next slide, please. And it's not just the inconvenience of not being able to see your GP or your practice nurse or your healthcare assistant in primary care. There are also safety issues. So increasingly we're getting research and data on the fact that these longer waiting times, this higher rate of demand in general practice has resulted in potentially compromise to patient safety. So how do you, when demand is so high, how do you know who's going to be seen in terms of a priority on the basis of safety? The other issue is, as demand rises, workload in general practice increases as well, and that's another potential contributor to worsening patient safety. So as well as the inconvenience, this slide makes the point about the fact that there's a safety issue underlying this, which is the main concern. Next slide, please. Thanks. So what's causing and driving some of these pressures in primary care? And then we'll come on to what we can do about it. So this is a really nice piece by the King's Fund. Came out a few years ago, but some of the main components of it still stand. And what the King's Fund, who are a policy think tank in London, did is they started reviewing and analysing what are causing some of these pressures in general practice. What are the things contributing to the fact it is so hard to see a GP or practice nurse? And in these sort of top bubbles, you'll see some of them. I'll just go through a few of them. So a rise in expectations from patients, the arrival of new services. Every time we decide on a new pathway or a referral pathway or a service, it actually increases the work in general practice as well. We know that just general demand is going up, but also the people that we're seeing more and more we know that we've got an aging population. So people are living longer, but they're living less healthy lives. So they're living with more disease, they're taking more medications. But we also know that there are other contributing factors, which we're going to allude to a bit more in this talk. Things like increased social needs, which has a huge overlap with health and well-being. Underpinning all that, we know that there's been a fall in the workforce, both practice nurses and GPs, and a year-on-year real-time drop in funding for what sort of services we're providing in general practice. So those are some of the pressures, and so those are some of the reasons why there's pressure in general practice. Next slide, please. So what can be done about this? So the NHS, recognising some of these challenges, have put forward a number of policies in place over the last few years to try and mitigate and manage some of these challenges. So it began a few years ago in 2016 with the General Practice Forward View, which is the policy on your left, which highlighted some of the things that we can do in general practice. That then was underpinned by a more broader policy, the 5-year forward view across the NHS, not just in general practice and primary care, but also in hospital care as well. And then more recently, the NHS last year released the NHS long-term plan, which took elements of both previous policies and presented a much more broader, as the name suggests, longer-term plan to try and mitigate some of the challenges facing the NHS, not just in primary care, but even in hospital care and community care as a whole. Next slide, please. So we're going to focus on a component within the NHS long-term plan policy. And the specific area we're going to focus on, next slide, please, is the fact that for the first time, probably in a little while, this long-term plan policy started to recognise some of the broader contributors to our health. So our health and well-being are influenced by a number of factors, not just our physical and mental well-being, which is the purple shaded area, but also a number of other factors, such as our economic, social, or environmental circumstances as well. And the NHS long-term plan made a specific point about recognising, if we're going to contribute generally and sustainably to people's health and well-being, we have to recognise the other factors that can influence that, like the environment, like the economy, like the social factors as well. Next slide, please. And part of the reason for that, and going back to primary care, is that we know from studies and analysis that about 1 in 5 consultations in general practice, and I see that in my practice, are for non-medical reasons. That's what we do. Next slide, please. And again, from a general practitioner point of view, we recognise, and now there's a greater recognition for the whole NHS to recognise that we need to manage people's health and well-being in a much more holistic way, a much more whole person approach to support people with these other elements, but also try to build internal activation to help manage their own health as well. Next slide, please. So the component we're going to focus on for the remaining part of this talk is a factor within the plan. So the long-term plan specifically makes this statement. So through social prescribing, the range of support available to people will widen, diversify, and become accessible across the country, with the aim that over 900,000 people are able to be referred to social prescribing schemes by 2023 and 24. So the idea here is recognising some of those elements I've talked about the broader contributors to our health, and specifically placing it within an NHS context through social prescribing. Next slide.
Okay, and this is where I'm going to take over from Kamal and talk a bit about, well, what do we actually mean by this thing, social prescribing? And social prescribing is about addressing those economic, social, environmental factors that Kamal's just mentioned. So social things like people being lonely, and we know that loneliness can really affect people's health and well-being. Environmental factors, things like the housing where people live, and economic things like debt and unemployment. These issues may be things that are first noted by a person's GP, but the GP may not be the only or the best person to help with those non-medical issues, those social, environmental, economic factors. And social prescribing is about drawing on things that are in the community already, existing assets, groups, services, charities, organisations that can assist with those difficulties that are environmental, economic, or social. So it's about directing, supporting people to make links with non-clinical sources of support, predominantly from the voluntary or the community sector. And what constitutes social prescribing activities is very varied. It can range from people being engaged in arts or cultural events to befriending. It could include gardening groups or exercise groups. It might include connecting people to luncheon clubs, to organisations like the Citizens Advice Bureau, and also volunteering can come under social prescribing activities. Here's a definition of social prescribing from the Social Prescribing Network, and they describe it as a way of enabling GPs to refer people to someone called a link worker who can give them support with their social, emotional and practical needs, again by drawing mainly on the voluntary and community sector. So as you will have seen in that definition, there's this notion of link workers. And link workers are being rolled out by the NHS in primary care to support the delivery of social prescribing. So link workers are being employed to work in GP practices, and what they do is they have time to talk to patients, to direct them to those non-clinical sources of support in the community. What usually happens is a GP might talk to a patient, the patient comes in to see the GP, and actually talking to the patient, the GP picks up that a lot of the patient's issues are mainly social, environmental, economic. So they might suggest to the patient that they could benefit from talking to a link worker. And if the patient agrees, they'll be referred to the link worker who has time to really find out what matters to that patient in terms of their health and well-being. So they might spend the first meeting with the patient talking to them for about an hour, but might also see the patient on several other occasions. And they're really there to help the patient to think about what are their priorities, what matters to them as an individual in terms of their health and well-being. And then with the patient, they'll co-produce, they'll develop together an action plan, thinking about how can we draw on what's existing, what's in the local community that can help with that person's specific health and well-being goals. I'm just going to give you an example of how this might work in practice. So here we have Mrs. Jones, and Mrs. Jones has recently been diagnosed with mild cognitive impairment. So this is a condition where they've got cognitive problems that are more than would be expected for the individual's age, but they've not been diagnosed with sort of dementia. And what happens often with these patients is they are referred back to the GP and are left without much other support, and that can leave them feeling quite isolated, quite alone. So Mrs. Jones has started to not want to go out as much. She's finding it difficult to concentrate on things. She's becoming reticent about interacting with other people. She's becoming quite isolated and quite low in mood as a consequence. Her husband encourages her to go and see the GP, and through talking to Mrs. Jones, the GP feels that maybe she might benefit from seeing the link worker. So he refers her to the link worker that's attached to the surgery. And the link worker has time to talk to Mrs. Jones to find out what Mrs. Jones values in life, what gives her life meaning and purpose. And then together they develop an action plan. So through talking to Mrs. Jones, the link worker finds out that she has a real ongoing love of history. So one of the things that they decide is that Mrs. Jones might benefit from volunteering at a local museum. She also finds out that Mrs. Jones used to really enjoy exercise, but is now becoming a bit less willing to do it because she's worried about her balance, but also about being around other people. So Mrs. Jones suggests that maybe, the link worker suggests that maybe Mrs. Jones would benefit from attending some chair exercise classes with her husband. And then the other thing that Mrs. Jones used to love doing was reading, but she's finding it much more difficult now to sit down with a book and concentrate on it. So the link worker suggests that maybe Mrs. Jones might benefit from being part of an audio book service with the library. And through being engaged in those different activities, the museum, the chair exercise and the audiobooks, Mrs. Jones starts to feel that there's more structure to her week, and she feels that there's sort of more purpose in life. And as a consequence, she's feeling less isolated, less cut off, less anxious, and just more content with her life. So hopefully that's given you a sort of broad understanding of what we mean by social prescribing. And Kamal and I are part of a team of researchers at the University of Oxford who are interested in research around this topic of social prescribing. It's an area of research that's really been developing over the last decade, and there's still a lot of unanswered questions. So if you want to find out more about what I'm going to talk about now, we have got a website that you can access more information. Today, what I want to do is to just give you some headline findings of some of the research that we've carried out already, and also to let you know of some of the research that we're going to be doing going forwards. So we've done a couple of projects looking particularly at that link worker role. And one of the projects that we did was looking at how is the link worker role being implemented across England. So what we did was we contacted clinical commissioning groups in England, and these are groups responsible for commissioning services in a specific area of England on behalf of the NHS. So at the time we were doing the survey, there were 195 CCGs, clinical commissioning groups, and we got responses from 162. And the survey, what we were interested in was, is your area delivering a link worker service? If so, how is it being delivered? And what we found from this survey was that yes, most areas, most CCGs were delivering a link worker type service. However, how it was being delivered was very varied in terms of who was delivering it. So in some cases it was an employed person, in some cases it was volunteers, in some cases it was an existing member of a practice. So for example, a healthcare assistant. There was variation in how people were referred. So in some cases it was the GP, and I'd say by and large, most services it was GPs who were referring. But there were other services where people could also refer themselves. And NHS England is trying to encourage not just GPs, but also other health professionals and other professional groups to refer to link workers, including paramedics and the police. And then there was also variation in who the link worker service was for. Often it was for all adults within a practice, but there were some services where it was sort of specifically for older people or for people with long-term conditions. And I think this variation that I sort of outlined was reflected in the terminology that was being used for this link worker role. So when we asked those CCGs, those 162 who replied, we got over 70 different titles for that link worker role. And I think that's important because people know what a doctor is and what a nurse does, but we don't really, it's still a new role, the link worker role. And if we're using all these different titles in different parts of the country, it might be hard for patients to really understand, well, what is a link worker? How can they help me? How can they help my loved ones? What can they do for patients? The second project that we looked at in terms of the link worker role was a review of existing literature on this role. So we looked at 118 documents that were focused on this link worker role. Again, I'm just going to give you some headline findings today. If you want to read more, we've published the review in this journal, BMC Medicine, and it is an open access journal, so you don't have to pay to look at it. So in terms of things that were required from the review, what we found was important for the link worker role to work effectively, first of all, was this idea of the importance of buy-in to the role of the link worker as a viable alternative to traditional medical care, or as complementary to medical care. And that buy-in was important and necessary from patients, but also from staff in primary care, particularly GPs, because they were the ones who were doing the referrals. Also, the importance of connections was highlighted in the review. So connections in terms of the relationship between the link worker and the patient. The patient needs to feel that the link worker is someone who cares for them, who's interested in them, who takes time to listen to them. And also the link worker needs to form good relationships with primary care staff, particularly GPs, if they're referring. And also the link worker needs to make connections with the voluntary and community sector, because they're who they're going to refer patients onto. So link workers need both people skills, but also need to be able to develop a good knowledge and understanding of what's available locally that they can refer patients onto. A key finding from our review was that working with link workers enables people to develop their social capital. And by social capital, we mean resources, which might be cognitive, psychological, instrumental, that are developed through people making connections with one another. So it might be things like improved self-confidence, an increased sense of belonging, or having access to practical support and advice. And there was this sense that through social capital, people developed the confidence, the skills, the connections that enabled them to better manage their own health, which then meant they were less reliant on the GP. As part of prescribing, one of the activities that link workers might refer people to is volunteering. So we've started to do some research around volunteering and what impact being a volunteer can have on people. So how does being a volunteer affect people's health and well-being? The study that we're doing on this involves a review of the literature, so that's what we're doing at the moment. Then in the autumn, we're going to start interviewing volunteers to find out what impact they feel volunteering has on their health and well-being. And then in the spring, depending on social distancing and where we are with that, hopefully we'll be able to have a stakeholder meeting in person. If not, we're going to have to do that virtually like today. But we're going to hold a stakeholder meeting after we've done the review and the interviews to, one, share the information that we've found, but also to get people to think about, if we're going to have volunteering as part of social prescribing, what do we still need to know about? So what are the other questions? So the stakeholder meeting is really about sharing our findings, but also thinking about what does that mean for future research in this area. The volunteering project stemmed from our connections with the Gardens, Libraries and Museums team at Oxford. So we've been doing quite a number of projects together. And one of the things that we did together was to develop a review looking at how gardens, libraries and museums can improve people's well-being. And if you're interested in the review, there is a link there to the review that you can access for free. And the review found that these venues, gardens, libraries and museums, seem to impact people's health in three ways. So in one way, they provide therapeutic landscapes. They're venues that are calm and relaxing and where people feel welcomed. They create a sense of flow. So they're providing activities where people can really get immersed. They can get immersed in the activity they're engaged in. And it means that they forget time just sort of disappears, and also forget about other worries and concerns in life for a small section of time. And then also engaging with gardens, libraries and museums can also improve people's social capital. We're about to start a project looking specifically at the cultural sector as part of social prescribing, and how that can support older people in the current sort of pandemic and as we come out of the pandemic. So we're going to start some research on that in the next couple of months. And that again is going to be a review of the literature and also interviews with different stakeholders: older people, people providing cultural sector activities, and also link workers. And there's a lot going on in terms of offerings of cultural offerings, but they can also be places of that offer well-being activities and support. So a number of these venues run activities for well-being for a range of different stakeholders, including older people, people with brain injury, for children. And if you're interested in finding more about what the gardens, libraries and museums do in terms of well-being, you can visit this website, and there's a lot of information there on the different projects that they run around health and well-being. I wanted to finish by talking about one final area that we've been looking at in terms of research, and that's social prescribing for people with mild cognitive impairment. So as I explained earlier on, people with mild cognitive impairment often get this diagnosis. They're not in the sort of dementia category, but their cognitive decline is more than would be expected for their age. And as I said before, they're often then referred back to the GP without much additional support. So we thought that maybe social prescribing may be one way of supporting people who have this diagnosis going forwards. What we did was we held what we called a sandpit, where we got together a range of different people to think about ideas for research on this topic of social prescribing and mild cognitive impairment. So the stakeholders included people affected by mild cognitive impairment, link workers and other social prescribing individuals, healthcare professionals, and also researchers. It was a full day with lunch, and by the end of the day, we came up with 4 ideas for research that were sort of co-produced by this group. So the first one was, what are the unique contributions that the cultural and heritage sector can make for the well-being of people with MCI, mild cognitive impairment? Who takes up social prescribing? So who with mild cognitive impairment takes up social prescribing, and what might be the barriers? The third one was around, what impact does social prescribing have on the cognitive decline or cognitive activities of people with mild cognitive impairment? So does engaging with social prescribing prevent cognitive decline? And then the final topic or question was around social prescribing for people whose family members have MCI as a way of supporting them. So hopefully that gives you an overview of sort of the range of different topics that we're researching now and looking to research going forward on social prescribing. I'm going to hand back to Kamal now, who's going to talk briefly about COVID and social prescribing and some of the work that's taking place at Kellogg in this area.
Thanks very much, Stephanie. Yeah, so just to sort of add on to some of those highlights of some of the projects that we're currently working on, and there are more that we're working on that we couldn't cover. But we were sensitive to how social prescribing might fit within the current pandemic. And if you are interested in this, we've written this piece here, which is published on our CBM website. And although we did a rapid sort of review of what evidence there was to explore how social prescribing, particularly at a time when we are very much, our health and well-being is very much being influenced by a number of environmental, economical, mental well-being, all these sorts of factors, social factors as well, are all influencing our well-being at the moment, particularly as a result of the pandemic. So we were particularly interested in finding what evidence there was out there on how social prescribing can help. And as you can see by the conclusion here on the bottom of that page, there was limited evidence, and partly that's because that we are currently in or emerging from, however you want to put it, and the pandemic. But there was increasing stories and narratives emerging about how social prescribing, even in the current circumstances and situation, was adapting to support the pandemic. So for example, link workers who would normally do face-to-face consultations were doing more virtual consultations. They were picking up different elements of need, and they were linking them to more to socially distanced, appropriate resources that were becoming more and more available. So there is an active adaptation to social prescribing in the current pandemic as well. So it was just to highlight that in this piece that we've written as well. Next slide, please. Thank you. So let's just bring this back to partly one of the reasons why we're all connected in this meeting, and it's no coincidence that the slide has the word connect. So this is the alumni magazine of Kellogg College, the most recent one as well. And I've put a picture of the front cover on there, which has His Royal Highness Prince Charles with our president, Press Jonathan Mickey as well. And that reflects a meeting that happened earlier this year, actually, just before the pandemic began, where His Royal Highness came to visit us at Kellogg College. And the reason why I'm highlighting this is because to bring this all back to something happening very much in Kellogg at the moment. And we've been talking about social prescribing, about looking at our health and well-being more broadly. We've been talking about the cultural sector and how gardens and therapeutic landscapes can support that. So I want to talk very briefly in this last couple of minutes about something that Kellogg is doing. Next slide, please, if I may. So I would urge you to download that. It is freely downloadable, the Connect magazine, and have a read of some of the plans that Kellogg College are doing. And I know maybe Nicola and I saw Rebecca on the call later on may mention something in the Q&A about this. But as the slide shows, Kellogg's developing or has developed fantastic plans to transform the gardens within the college grounds, and very much taken an approach with a fantastic lead gardener and designer, very much taken that approach about using the garden space to improve well-being, to improve the students' and visitors' lives and experiences rather within the college space. So next slide, please, if I may. Thank you. And I've added into the magazine in this particular issue just a short article about how we can link some of the challenges that we're facing in the NHS, in primary care, and through the opportunity that social prescribing can provide, how we can link that to some of the things that are happening both in the college and even outside in terms of enriching our environments and garden spaces as well. So next slide, please. So again, on behalf of Stephanie and myself, I want to thank you very much for your virtual and online attendance. I hope it was interesting, and we're happy to take any questions via our facilitator. So thank you for your time.